Hi, this is Dr. Sham and welcome to my YouTube channel. We're going to talk about today the OSA, that is obstructive sleep apnea. That's also obstructive sleep apnea hypopnea syndrome, OSAHS. So first of all, it is actually um, and the patient in OSA or OSAHS, it experiences apnea and the hypopnea because of the upper airway narrowing, and it is associated with the daytime excessive sleepiness. So first of all, we're going to talk about the definitions because these terms need to be understood. The first one is the apnea. What is apnea? So apnea is actually it is complete cessation of airflow. What is hypopnea? It is diminished airflow that is associated with at least 3 to 4% oxygen desaturation. So these are the two things. Now all these respiratory events they must last at least 10 seconds to be counted. So this one episode of apnea we are calling our hypopnea that should last for like 10 seconds. Now the next thing is RERA, that is respiratory effort related arousal. That is change in the airflow that leads to an arousal, but that doesn't meet the criteria of apnea or the hypopnea. So that is going to be respiratory effort related arousal. So if um, anything that is not meeting the criteria of apnea, hypopnea, but that leads to the arousal, okay, that the thing is similar to the apnea or hypopnea, that is called respiratory effort related arousal. Okay, so the next thing is apnea hypopnea index. Now this is important. So apnea hypopnea index is the number of apnea and the hypopnea per hour of the sleep. Okay, and what is respiratory disturbance index? It is the number of apnea, hypopnea, and this RERA per hour of the sleep. So apnea hypopnea, that is um, apnea hypopnea index is number of apneas and hypopneas in a hour, but this respiratory disturbance index that includes all this apnea, hypopnea, as well as respiratory effort related arousals. So these are the definitions. Let's move forward. So the next thing is what are the risk factors which lead to the this obstructive sleep apnea? So this obstructive sleep apnea, it affects more the men as compared to the female, as compared to the women. So obesity, that is a great risk factor for that. If the BMI is greater than 30, particularly neck circumference, that is important. If it's greater than 17 inches in a man or greater than 16 in female, and then there was the third thing is increase soft tissues of the posterior oropharynx. That includes enlarged tonsils, macroglossia, or and abnormal jaw structures as well, like micrognathia or retrognathia. That is actually, these are the risk factors for obstructive sleep apnea. Let's move forward to the presentation. So how does a patient presents with that? They have a loud habitual snoring, that is the very first thing. Then they have excessive daytime sleepiness. This is a classic symptom of obstructive sleep apnea hypopnea syndrome. Patient may describe the feeling falling asleep while driving, and that's why these are prone to the vehicular accidents as well. Then, if you cannot sleep at the night, you have headache, okay, you have chronic fatigue, intellectual deterioration is there, personality changes are there, morning headaches or irritability, depression. These all are the symptoms of OSAHS, that is obstructive sleep apnea hypopnea syndrome. Most common is this habitual loud snoring, and excessive daytime sleepiness is a classic symptom. So these two are very important. And let's move towards the diagnosis now. So if we talk about the diagnosis here, so The test is polysomnography. This is a gold standard test. Polysomnography. So, overnight polysomnography will with direct observation by a qualified technician. So, what is there in the polysomnography? There's ECG, there is electromyography, there's EEG, um, yeah, and there's electrocoolography, measure the oxyhemoglobin saturation, and the effort as well as the assessment of respiratory airflow. So these all things are included in the polysomnography. Um, Now, in this polysomnography result, okay, what we do is that um, we demonstrate the obstructive events with an RDI, okay, that was respiratory disturbance index. What was that? Apnea, hypopnea, and respiratory effort related arousals in 1 hour. So if the score is greater than 5, this means that the patient has got the OSC. This is a diagnostic of OSC. Now, if the RDI is between 5 to 15, a patient may qualify for CPAP, okay, if there are the comorbid conditions, a hypertension, coronary artery disease, or the depression. And if that is greater than 15, so this means that the patient qualifies for CPAP no matter the other things that coronary artery disease, depression, and hypertension are there or not. So greater than 5 means that it's a diagnostic of OSA. 5 to 15, this is like now we are deciding for the CPAP. Okay, you know that the CPAP is the choice here. So 5 to 15, if the comorbidities are there, which I have told already, so it's for CPAP. And if it's greater than 15, even nothing, no comorbidities are there, it's for the CPAP. So it's all about polysomnography. Yeah, we do the polysomnography, but all the patients they should go through ENT examination, nose and throat examination. Okay, and because if there's a reversible cause, we can reverse that, and that's going to give an idea actually. Um, that might not actually reverse if there's an ENT cause, but it gives you an idea that why it's causing that, and yeah, you can then treat that accordingly if there is something that is reversible. So ENT examination and the polysomnography. Now, what is the treatment? That is important. So, if there is a potential correctable cause, reversible cause, go for that. And treatment is different. Like it depends. We individualize the treatment. It must be highly individualized with the special attention to the correcting the potential reversible exacerbating factors. So, CPAP, that is positive airway pressure, that is the choice here. Okay. So go for the CPAP. There are two types, like nasal CPAP is a current treatment of choice, and the other one is the use of a full mask. That's a oronasal. That is particularly useful for the people who are mouth breathers. Okay, so there you can go for the mask. Otherwise, go for the nasal CPAP rather than the oronasal. That has a mask actually. Now then, oral appliances are as well available. These are mandibular advancement devices. These are for the mild OSA. Okay, and the upper airway stimulation devices like a hypoglossal nerve stimulation. Okay, and actually, when we stimulate that one, it improves the tongue protrusion, and it is used in the patient with moderate to severe sleep apnea who are not responding to or who cannot tolerate to actually to the CPAP. So the CPAP is first. If that's not working, you can go for the oral appliances and the hypoglossal nerve stimulation. So moving forward to the treatment, are there any medications? First, we talked about the devices there, CPAP, the device is there, and now the medication. So the medication modafinil is there. Um, it may improve objective and subjective daytime sleepiness. The patients with persistent symptoms despite adequate use. So it's not like that you're going to introduce the modafinil as first one. No, it would be like CPAP, but if still the patient is symptomatic for the daytime sleepiness, despite the CPAP use, one can use the modafinil. Yeah, and the surgery, the third one is, so first is appliances, CPAP appliances, medications, and now the surgery. Yeah, most common surgical treatment for mild to moderate patients who do not respond to the therapy, the CPAP and the medical therapy. The problem with actually the surgery is that it is only approximately 50% success rate. It has a 50% success rate. And the other problem is that it may an improvement actually that has is related with the surgery that may diminish over time. So it's a 50% success rate, and then over the time the symptoms start reoccurring. Thus, it is considered as a second line. That's why it is the surgery is a second line for the people who cannot tolerate the CPAP, have tried the medications and that's not working. So that's about the treatment. So CPAP, that's the first line. We have the devices, we have the medication and surgery. They come as a second line. It depends on if they are not responding to the CPAP, and you should individualize that where you're going to use the devices, where you're going to use the medication, and where you're going to go for the surgery. The last thing is about the complications. So the complications are hypertension, okay, heart failure, arrhythmias, and these two can lead to death as well. Um, it is seen that like the people who are having this obstructive sleep apnea, they have increased prevalence of diabetes as well. That has been noted in these patients, independent of the obesity. So it is linked with the diabetes as well. And the last thing is the vehicular accidents, because they have excessive daytime sleepiness, so can lead to the vehicular accidents. So they should be very, very much aware of that thing, and they should take care. Sometimes poor neuropsychological functioning, it rises with the increasing severity of OSA as well.